Thank you very much for the opportunity to present the results of the National Heart Failure Audit from 2021. I'm Theresa McDonagh, the clinical lead. In terms of the numbers of patients that I'm reporting on in the collection year from April 2019 to March 2020, there is a slight reduction of 7% on the previous year's report. We're really looking at just under 70,000 admissions with heart failure in the first diagnostic position. And I suspect here we're seeing the first 2 months of the COVID pandemic impacting on data entry. However, overall, we are still representative here in that overall between England and Wales, the submissions represent 80% of all heart failure admissions to hospital in the first diagnostic position. So going on really to look at the highlights and the lowlights of the audit, and I'm going to focus on the key performance indicators, starting with the main diagnostic one, which is the use of echocardiography to get the correct diagnosis for patients being admitted to hospital with heart failure. We've seen a slightly worrying trend, and last year only 86% of patients being admitted to hospital with heart failure had an echo as an inpatient. That was higher if you were on a cardiology ward at 93%, or if you saw a specialist at 90%. If we look at the inter-hospital variation and benchmarking, if we set a target that 90% of patients being admitted to hospital with heart failure should have an echo as an inpatient, we see that 60% of hospitals achieved that target last year, which is a very slight improvement of 1% from the previous year. Another important key performance indicator is the place of care, because we know that admission to cardiology wards is associated with better outcomes for heart failure patients. And indeed, it's a Care Quality Commission quality indicator. And we see here again a worrying trend of a reduction in those being admitted to cardiology wards, and it was only 43% last year. There is great inter-hospital variation from 0% of patients to 100% of patients making it to cardiology. And if we set an aspirational target of 60% of patients getting into cardiology, we see that only 1 in 5 of our hospitals submitting data achieved that target. Specialist input from a heart failure cardiologist, a heart failure nurse, or another clinician with an expertise in heart failure again improves mortality and morbidity of heart failure patients. And overall, 82% of our patients last year were seen by a heart failure specialist, and just over half were seen by a heart failure specialist nurse. You're more likely to be seen by a specialist if you go into a cardiology ward. And if we look at the overall inter-hospital variation and we look at the 80% benchmark, which is set by the best practice tariff, 64% of hospitals achieved that target of 80% of their admissions being seen by a heart failure specialist, and that was up an increase of 3% of hospitals on the previous year. What about treatment? Well, we know that for a subset of patients with heart failure, those with reduced ejection fraction, treatment with an ACE inhibitor, an ARB, an ARNI, beta blocker, and an MRA improves mortality and morbidity. Overall, prescription rates, aggregate prescription rates for ACE and ARBs are high at 85%, beta blockers at 90%, but there's a bit of a fall off for MRAs, that's spironolactone and eplerenone, 56%, and consequently the chances of being on all 3 disease-modifying classes of drugs is less than 50%. You also see the worrying trend here in prescription of disease-modifying therapies by age, and worryingly that reduction in prescription rate seems to start when people are in their mid-50s. If we look at the overall trends in prescribing of these drugs over the last 6 years, ACE inhibitors and ARBs remain static and with high prescription rates, but we're seeing only a very slow uptake in the prescription rates of MRAs on being on all 3 classes of disease-modifying therapies. As usual, you're more likely to get all the correct drugs when you see a specialist or you're admitted to a cardiology ward. If we look at the inter-hospital variation and set benchmarks of 90% of patients with HFrEF should be discharged on an ACE inhibitor, an ARB, or an ARNI, then there's no change really. 44% of hospitals managed to achieve that target. The picture is better for beta blockers last year in that there was an increase from 56 to 66% of hospitals achieving the 90% target for beta blockers. The worrying and persistently worrying news is for the MRAs, with only 48% of hospitals achieving 60% of their patients with HFrEF going home on an MRA, very slight increase of 1% over last year, and overall only 39% of hospitals managing to discharge their patients with HFrEF on an ACE or an ARB or an RNA, a beta blocker and an MRA, a slight drop from last year. This may have something to do with length of stay, because we know that patients seen by specialists and being admitted to cardiology wards have a greater rate of prescription of these drugs, and the median length of stay in cardiology for those achieving specialist care is higher at 9 days. You don't see a specialist, your stay in hospital, it's 5 days on median, or if you're in general medicine, it's 6 days. So there may be an interaction here that we wish to explore in subsequent audits. Looking at the harder outcome data, particularly all-cause mortality, it was unchanged last year at 9% for patients being admitted to hospital with heart failure, and the 1-year mortality after an admission, 32%, again unchanged and unfortunately remaining high. That mortality, of course, does change with age and where you are in the hospital. So 6% mortality rate for those admitted to cardiology wards, just under 8% if you see a specialist. And if we look at reductions in mortality over the last year of the audit reporting, you can see there was only a reduction for those under the age of 75 and those admitted to cardiology wards. All the other mortality rates were static. Now, of course, many things affect the mortality of heart failure patients, particularly related to disease severity. But even when we account for those in a multivariate model, when we look at death in hospital, not being a cardiology inpatient is still a highly significant predictor of a worse outcome. In fact, the increased risk of not being in cardiology is 77%. But it's not only death in hospital that's affected by the quality of your care, it's what happens to you subsequently. So if you are discharged home from hospital with HFrEF on all 3 classes of disease-modifying drugs, your 1-year mortality is just over 10%. If you're on none of those drugs, it's over 40%. Again, if you've been admitted to a cardiology ward, your 1-year mortality is less than if you've been admitted to a general medicine ward or a care of the elderly ward. There's also effects on the follow-up that you receive. So if you receive cardiology follow-up, if you're seen by a heart failure specialist nurse, or you're referred to cardiac rehabilitation, your outcomes are significantly better at 1 year than if you are not. So to try and summarise the good things we've seen in last year's heart failure audit, I think the quality assurance remains high, despite a slight downtrend in admissions, which is probably COVID related. We're still capturing more than 80% of heart failure admissions to hospital in the first diagnostic position, so we can be fairly sure of our results. Inpatient mortality is static despite an ageing population, and we have seen a slight reduction in mortality for younger patients and those admitted to cardiology wards. And in terms of disease-modifying drug prescription, we have seen a 10% increase in the number of hospitals managing to send home 90% of the patients with HFrEF on beta blockers. So those are all good. What about the lowlights, or the red flags and things we need to work on for the next year? Well, I think very worrying is the marked reduction to diagnostics, drugs and specialist care for older people, and that That plays out both in the aggregate data we report and in the hospital variation benchmarking quality improvement analysis. So we definitely need to work on that. There is a worrying trend for those being seen on a cardiology ward, now only 43% of patients. We've often thought this might be a structural barrier with a number of cardiology beds in hospitals, but I think undoubtedly we're seeing a signal here that's a call to action to try to reverse this trend and improve the number of patients being cared for in cardiology wards. Specialist input to care is static, and that's a bit worrying if we're seeing less in cardiology. And we're seeing a downward trend for the use of inpatient echocardiography, which is fairly key to getting the diagnosis correct, for which all the other care quality metrics follow. So that's a quick look at the last year's results. I'd just like to thank all those who helped with the drafting of the report, the analytical team at NICOR, and the advice we've had from the heart failure domain expert group. Thank you.